On behalf of the World Affairs Council, I'm Stephen Kahn, your moderator for this evening. It's now my pleasure to introduce tonight's distinguished guest. Dr. Eric Bing is an accomplished global health researcher with concurrent appointments as a senior fellow and the director of global health at the George W. Bush Institute, and as a professor of global health with Southern Methodist University in Dallas, Texas, both at the School of Education and in the Department of Anthropology. Bing received his medical degree from Harvard Medical School, a master's in public health, and a PhD in epidemiology from the University of California, Los Angeles, and an MBA from the Fuqua School of Business at Duke University. As director of global health at the Bush Institute since 2010, Bing has initiated worldwide health initiatives, including serving on the steering committee of the Pink Ribbon, Red Ribbon Partnership, an $85 million public-private program spearheaded by the Bush Institute and other partners and designed to combat cervical and breast cancer in Africa and Latin America. I'm particularly interested to hear from Dr. Bing how we can be informed by his experience and the case studies he reviews in his book to learn from our mistakes and change paradigms so that tomorrow we can better address the world's tremendous health disparities. Ladies and gentlemen, please join me in welcoming Dr. Eric Bing.
Well, Stephen, thank you for that very, very kind introduction, and thank you all for coming out here on tonight. It's a really nice night out there, and appreciate you coming out to hear what we're going to talk about, which is really sort of the focus of my life's work about how to get health care to those who need it most, where they need it, in ways that they'll use it, and also at a price they can afford. And it's a topic that I focus on in my book, Pharmacy on a Bicycle, that I co-wrote with Mark Epstein, which I'll tell you a little bit more about as we go along. And so thinking about my life's work, I'm going to sort of tell you a little bit about sort of what I've done and sort of how I got into this. I began really focusing on issues of poverty right here in the United States, because we have many, many people here who are poor and who don't get health care. And that's really where I focused for many years in South Los Angeles. However, as you know, poverty doesn't end at our borders, and really it begins to broaden and sort of go south, and so did I. And so that's actually when I began working in Africa after many years working in South Central Los Angeles at Drew University. And I was first drawn to a country called Angola in sub-Saharan Africa, just a little north of Namibia, and this was about in the year 2000. They were still in the middle of a civil war, a really bad civil war, and they knew that they had an HIV problem, but didn't know what to do with it. And I got a call and was asked to come help, and I said, sure, I'll go. It'd be a lot of fun, because this really is important work. And so when I got there, I was really not prepared for what I saw and what I was about to experience, because I had worked with really poor people here in South Los Angeles, people who were homeless, but they were able, with support, to get on antiretrovirals and get on medication and really begin to live full lives. And then when I got there, it was something very, very different. So when I got there, I was whisked away and to the major hospital called Josini Michel, which is in the capital, and it was just teeming with patients who really had come there to die because they didn't have any medications. They didn't even know if they were HIV positive because they didn't have HIV tests. And really what I came there to do was to help the clinicians help these people die in dignity, because that's all they could do. And it became clear to me that the challenges that we were having in global health had nothing to do with medical know-how, because we knew how to solve these problems. What we did have, however, is a logistics problem. How to get care to people who need it in the way that they'll use it and at a price they can afford. And that's a business challenge. And I began to teach the doctors there business. And they listened to me, not because I was a business professor, I had no business training, but I was a doctor, and doctors listen to doctors. And as I began to understand sort of the challenges that they were having, I began to do things differently. But the whole world was also doing it too, because what we were doing wasn't working. We had a huge logistic problem. And it's business that can help us come to some resolution of this problem. So I'm going to tell you a little bit about sort of where I've been and what I've been doing, because the challenges that we have, it's kind of a puzzle. You know, we have an access issue, we have a use issue. People need to use the services, a quality issue, and really a cost issue. And it's only when we begin to sort of deal with all of these, access, use, quality, and cost, are we able to put a system together that actually works. So I'm going to go through what we do know that does work in many of these very, very poor communities. For those of you who've been to any third world country, you know wherever you go, you can find a Coca-Cola. No? You'll find it in whatever out-of-the-way place you go. And not only that, they will give it to you, they'll sell it to you with a smile as they take your money. Because they're entrepreneurs, they know how to get out there. And they're able to sort of get it all over the place, in Africa, in Asia, in Latin America, throughout the Middle East. Apparently, you know, they can even have animals who can drink this stuff. People love it. Why? Because entrepreneurs sell it. They get it out there. So Coca-Cola in Atlanta is not doing all this. They've task shifted this to countries, who then task shifted their work to cities, who then task shifted their work to local entrepreneurs who get it out to the community. And it's not just Coca-Cola that can do this. Cell phones are ubiquitous. They're all over the place. Wherever you go, I'm sure you can probably find 5 bars. I digress for 1 minute. I took my son for his 13th birthday to India, and Brian was really, really excited. I was going to take him to the Great Wall for India. The Great Wall of China for his 13th birthday, and we sort of rushed there, and he finally gets to the Great Wall of China at the moment of his 13th birth, and I thought we were going to have some great kind of father-son kind of bonding over this. No, what he does is he takes a picture of himself from the Great Wall of China and then puts it on Facebook and tweets all of it to his friends because he has a great internet connection there. And this really has changed the way we're able to do work now in global health. And why we're able to do this is because we have entrepreneurs and companies that are really pushing it, and people are then using it. Well, if we can use it to get Cokes out there, and if we can use it to get cell phones out there, can we also use it to get mosquito nets out there? Can we also use it to get all the things that are necessary for healthy communities? And we are, and we have. So why now? Why can we do this now? And I really believe that we're at a crossroads in our ability to scale up what we've been doing for many, many years in global health, so that poor health doesn't have to coincide always with poverty, that you actually can be poor but still have good health. And part of that is going to be with some of the technology and business innovations that we have today. So there's been significant some technology innovations. As I mentioned, we have cell phones that are all over the place, and they're ubiquitous. 6 billion cell phones for 7 billion people. And in about a year and a half, we'll have more cell phones than we have people on Earth. And 3/4 of these are in developing countries. Where I work in many parts of sub-Saharan Africa, about 70% of the people have access to a cell phone. It's become a great equalizer. And we can now begin to use it to text people about coming in for their appointment. to send people little reminders, to task shift from a hospital to a community group where they can sort of call the doctor up or call the nurse up who's almost always in the city about what's wrong. Allows us to sort of do that now. We actually have telemedicine now. We have video conferencing. So you can be in the very rural area and speak and see a doctor or a nurse or a technician in a city. It moves everything out. We now have generic medications in lots of companies throughout the world that are producing these at really inexpensive costs. Combination medications where they're able to put pills together to make it easier to take. Easier diagnostics that allow you to take things and move it to the field, really beginning to move things from the hospital and the laboratory to the communities. So we can begin to change the business of healthcare. And all this stuff is now beginning to move so that entrepreneurs are able to be effective where they are and give quality care. As I mentioned before, that we're able to task shift a lot of the stuff that's actually happening at hospitals to clinics, to communities, and from really highly skilled people to people who are trained to do just that. We're able to have franchises. And if we can have a franchise for hamburgers, we can also have franchises around healthcare. And it allows these entrepreneurs to actually have a brand identity from the franchisor, and then do their things in the community and be supported. In addition, we now have banking for the poor. This with things like M-Pesa or mobile money. These things are now beginning to create a tremendous amount of headway in very low resource settings, so that you actually can have poor people who may not have a bank, but still be able to collect charges and pay simply with a cell phone. This is actually now beginning to change the business of healthcare in developing countries. And then we have new public-private partnerships. People who are coming together, who are working together, governments, NGOs, businesses, local entrepreneurs who are now working together to significantly change access to care for people in developing countries. You know, one initiative that has been in the news a lot recently is Gavi, which has was started by a number of the pharmaceutical firms, the Gates Foundation, countries, and what they've been able to do is come together to negotiate pricing for vaccines. And then what they're able to also do is to work with countries to create demand for the vaccines and then begin to forecast how much they're going to use. What this does is dramatically drop the pricing of vaccines and then gets it out to the community. This is a business innovation that is really beginning to also increase our access to care for these populations. In the book that I've written, Pharmacy on a Bicycle, Innovative Solutions for Global Health and Poverty, I actually wrote this with Mark Epstein, who is a business professor at Rice University. And just as I've worked in healthcare most of my career in developing countries, what he's done is actually worked in businesses, entrepreneurial businesses in developing countries. And what we've done is come together to begin to understand about how do we begin to scale these things up, using business approaches to global health. What we've done is looked at a number of organizations throughout the world, over 100 organizations that are beginning to use these business approaches to dramatically save lives. And have come up with a model which we call Impacts that focuses on innovation, that's the I, and entrepreneurship, maximizing efficiency and effectiveness, creating partnerships that work, systems of accountability, having targets, having goals. That's what businesses do. Creating demand for services. And if you don't have demand for services, it makes no difference if you have the service. Nobody will use it. And so creating demand is critical. Task shifting, and then also moving to scale. And so I'm going to tell you a little bit about a number of these different organizations that are doing this. In Rwanda, where I've worked since about 2006, the government is now beginning to function much more like a business, an effective business, using many of these features that I just talked about in impacts. And one of the things that they were really grappling with in around 2000 is that they had really high rates of maternal and child mortality. Very, very high. In Africa, they're about one of the worst countries. And as you know, Africa is about the worst continent for maternal and child mortality. And so this was the country that had the worst on the continent that had the worst. What they did, however, is they said, what do we have is we have people who are entrepreneurial and who are innovative and will help us solve this problem. So what they began is a volunteer community health worker program. They now have 45,000 volunteer community health workers throughout the country that live in the community and then go out to the community. And have targets for the number of women they will identify who are pregnant and make sure that they get appropriate prenatal care. So you would sort of think, well, why would a person sort of volunteer to do that? This is actually a lot of work. Well, I don't know about many of you, but how many of I volunteer for lots of things, and many of us volunteer for lots of things, whether it's the condo president, or president of your department, or any block captain. People will do these volunteer positions because the community has asked them for it. And they have status, they have support, they're recognized within the community. And so that's one of the ways we're able to get these volunteers, and they're not chosen by the government, they're actually chosen by the communities as the people who will be there to support them. So while they may not get money, they do get a lot of recognition and status. And they then go from house to house and make sure that anybody who is pregnant gets the care that she needs, and they're connected to the Ministry of Health and the clinic, often by a cell phone. And when they find a woman who is pregnant, they can actually just text it in when her last menstrual period was in order to estimate when she should go in for her prenatal visits, when she's going to be delivering, and when her postnatal visit should be. And they get it immediately and tell the woman right then. So, ways of keeping them connected. The other thing that Rwanda has also done is something called performance-based financing. And what performance-based financing is while people may get a salary in a government clinic, if your performance, the clinic's performance is really good and they're meeting all the deliverables, they get a little bit more. So then then hospitals want to actually go the extra mile, do the extra thing, so they actually get the resources for the hospital and also are able to build it up. And this actually has been extremely helpful in moving their service forward. And the same thing actually happens with these these volunteer community health workers. Those who actually meet all the deliverables, their community actually gets a little incentive. So now you have the entire community looking for these pregnant women and making sure that they get care. It's to stimulate everybody to do the right thing. And this isn't just happening in Rwanda. Rwanda has been able to drop its infant mortality and maternal mortality over 50% in just the past 12 years with this program and with other things that they've actually done. Very, very focused, entrepreneurial, using good, sound business and management techniques. And other countries are doing this as well, from Malawi to Ethiopia to Nepal, with very good successes by just having an army of people who are now going out to do good care using business techniques. Other organizations are using this as well. Living Goods, which operates in Uganda, has about 1,000 women, mostly women, all women, entrepreneurs who are trained how to be basically Avon ladies. For those of you who remember the old Avon ladies, I'm not sure they even have Avon ladies anymore. But when I was a kid, they do. When I was a kid, we had them. And they go, just like Avon ladies, door to door and sell the wares and get people to understand how to use them, and it's not just health products they sell. Like they sell soaps, they sell shampoos. But if you're in a community, because they're entrepreneurs, if you need a phone charger, they'll sell you a phone charger. If you need a clean stove or clean smoking stove, they'll sell that to you too. If you need a solar energy panel, they'll get that too. And because they're part of a franchise, all their prices are very, very low. And so that's one of the ways that they're able to do it, is their prices are kept low and they're able to be competitive in the community. Vision Springs is another organization that also does this as well. They're different, however, because they focus on eye disease. And if we have about 19 million children out there who have impaired vision, and about 60% of those can be corrected with simple pair of glasses. So what they've done is they have these business in a bag operations, and they're trained these providers, entrepreneurs, to simply go out into a community and go where people need vision. They go to schools, or they'll go to businesses where vision really matters. And they train them to do very, very simple things. You go there, you talk to a person. They don't have a ton of training, but they put a eye chart in front of a person, and they have a string, and they walk back like 10 paces, and they put it up and said, "What can you read?" And then they say, "Okay, you need this kind of glasses." And then they go back and they sell it to them for about a couple of bucks. Inexpensive glasses for these populations who would otherwise be without. And when they work with businesses, they can often get the businesses to pay for the glasses, because a worker who can see better actually works better. More recently, they have been struggling with how do they scale up, because the challenge of having all these entrepreneurs is that you actually have to train all these entrepreneurs. And what they said, this doesn't really make good business sense, because there's not a lot of places that are out there manufacturing these really, really cheap glasses, and not a lot of places understand how to do them in low-resource settings. So what they did is they said, we're going to focus on producing the glasses and helping others train the entrepreneurs. So they partner with places like BRAC, which is the largest NGO focused on poverty in the world. They have a tremendous number of people. They work with other micro-financing organizations, so that they focus on producing the glasses and selling them to the organizations, and that the organizations do the distribution. Very good business skills. You have Child and Family Wellness Clinics, which is based in Kenya, which recently moved to Rwanda. And what they do is they take retired nurses. I've actually been to these clinics. They take retired nurses and they turn them into entrepreneurs. And they charge a small amount for their services, and they focus on just the most common services that people need around well child and baby systems. Care. When I went to one clinic in Nairobi, I asked one of the practitioners, "So how do you do this?" And she says, "Well, it's you got to figure out sort of where the people are. They congregate on this corner. I can actually sort of get to them, but I can't get to them by myself, because if I'm out there, I can't be in here to get to provide services." So what she does is she has these young kids, these young women, and she pays them a little bit, and they go out and they drum up business for her. They find folks. They bring them into her, and she treats them very, very differently than the public clinic across the street. Because when they come to her, they don't have to wait. And when they come to her, she always has the medications, because she's thinking like a businesswoman. And at the end of the day, when they've gone home, she calls them up to make sure that they're feeling okay, that they're doing okay. And by being an entrepreneur, she's able to get people to come see her. She makes a living, they get better, and the system works. And you may say, well, why would a person who is poor rather go to see her when they could go to the government clinic across the way? It's the same thing that we do. It may cost us more, but if we think the quality is better or if we're treated better, we'll actually pay for it. And that's actually the thing that she's able to do, these clinics are able to do, and in order to provide good care. And in Rwanda, they now have government-backed health insurance that they can also charge as well. And that's actually also been extremely helpful. But it's not just with basic care that we are able to use these business techniques and these management skills in order to increase care to the poor throughout the world. Even much more advanced things, such as cardiac surgery, we're able to do as well. And this is a hospital, NH, which is based in Bangalore, that has really perfected this by, in some ways, creating what is they would call sort of assembly line care. What they do is they focus on being extremely efficient in their care because they're committed to the poor. And the only way they can actually create a sustainable system is by providing care to the wealthy, because it's a for-profit system. And so they create extremely efficient ways of providing care so that the doctor is only doing things that the doctor needs to do. And it's very, very high quality. And the way they see patients, everything is monitored so that they know each day how much money they've made, so that they can then use that to see the poor. It's very similar to, you might, when I came here today, I was sitting in coach, and there are people sitting in first class, and they had meals and other kinds of things that I didn't have. And they paid a lot more than I did. And in some ways, they subsidized my flight. We both got here safely. We both got here comfortably. They just got here a little bit more comfortably. And we can do these same things in healthcare in order to provide care to the poor as well. We have NH is actually doing it now in India. They not only do this, they're also expanding via telemedicine. So they support over 100 hospitals throughout India just with telemedicine, 50 hospitals in Africa just with telemedicine, and all of it's for free. However, they're also looking at ways of expanding. So they're about ready to build another hospital right in the Cayman Islands, which is really close to us, about 20 minutes from Miami by plane. And this will be also a for-profit hospital. And so people will then, Americans and people, South Americans will fly there, get excellent medical care, probably pay a little bit more than they pay in Bangalore. But that then goes to help the poor wherever they're working. So it's a business model that actually works for them and can also work for us. There's another organization that you may know called Aravind that does a very similar thing with cataract surgery. It creates incredible efficiencies in order to reduce costs, but really good on quality and efficiency, and is able to bring care to the poor. About 2 years ago, I moved to the George W. Bush Institute, which is a think tank that focuses on actions that create change. And our first initiative is a program called Pink Ribbon, Red Ribbon, about how to combat cervical cancer. Because as you may know, about 250,000 women die each year of cervical cancer. And almost all of them are in developing countries. But these things are really easy to treat now because we have vaccines that can reduce girls' risk of getting HPV, the virus that causes cervical cancer. And you can also diagnose and treat cancerous lesions in women really, really easily. And Pink Ribbon, Red Ribbon is a public-private partnership between the Bush Institute, Susan G. Komen for the Cure, the U.S. State Department, UNAIDS, and a number of different corporations and countries focusing on combating cervical cancer. And the reason why it's so easy is because all it takes to diagnose precancerous lesions is a drop of vinegar. It's really simple. And when you put the vinegar on the cervix, you get a white lesion that is easy for the eye, a trained eye, to see, and you can do this right in the community. And then because HPV is just a wart, you treat it like a wart, and you use a cold probe to burn it off. And this makes it really simple and easy. And we've started this now in Zambia and Botswana, and we're about ready to expand it to a number of other countries throughout sub-Saharan Africa. And one of the things that I did recently is I was speaking when we started this initiative, and when we began sort of talking to the nurses about how to scale it up, the nurses immediately went to, why don't we do this privately? We could do this more efficiently if we do it ourselves and we take it out into the community. So they're always sort of thinking about how do they scale it up, and they've begun working with some micro enterprises in order to get the money in order to do this. I also recently spoke with some doctors in the hospital, and we were talking about pharmacy on a bicycle and some of the probes that we have in there to help communities think more innovatively about ways of getting care to the poor. And one of the questions that we have in the book is, how could you double the number of people you see within the next year? Because people can figure it out how to do it. They understand their system. And so I said to her, well, doctor, how many patients are you seeing per day? She says, I see 80 patients a day. I thought to myself, my God, 80 patients is a whole lot of patients. So I said, so how could you double that? Could you see 160? And without a beat, she says, absolutely. I said, what would you do? She says, this is actually what I'd do. All I need is 2 more technicians. If I had 2 more technicians, they would have all the patients lined up for me before I even got there. They would have all their vitals already done, and I would just go see them one by one by one. It'd be really, really quick. Everything would be very efficient. And I said, she said, there's one problem. She says, the government makes me write my notes, and there's no way that I can do my notes. She says, so if you give me another technician who all they did was write my notes, I could actually see the patients, just do the stuff that I do, and let other people do the stuff that I don't need to do. And that's how I could see 160 patients. Don't know if she can do this. However, these are the types of innovations that we can begin fostering using just sound business and management skills in order to scale these things up. Because really what our whole goal is to allow people live with dignity. And just if we can do the same things that we do with Coca-Cola and with cell phones, and do it with healthcare, we're already doing it. We now just need to scale it up. So thank you very much. I'm happy to talk and take questions and answer anything that I may have raised. I went through this relatively quickly, but there may be a lot more things that we can talk about.
Excellent. When I was here moderating a session at the World Affairs Council last time, I was speaking with Amy Willentz, and she actually took exception with our natural obsession with scale. And have you seen ways in which our too urgent demand for scale has actually thwarted progress, or perhaps by squelching local voices or local knowledge that is essential for success?
Yes, so when I think of scale, it really means reaching more people. And all these interventions, all these programs need to be adapted to local conditions. And I think that's why it really means relying on local entrepreneurs in order to take this thing to scale. There may be some key elements within a particular program or a particular approach, but that always has to be adapted to the local community.
Great, great. I have a number of questions. I also really interested in a lot of the things you discussed. You mentioned the working in Rwanda and the national community-based health insurance scheme, and I've learned about that a little on my own. The Mutuelles de Santé, and I think this provides insurance for 97% of Rwanda's populations and has premiums and co-payments that vary based on income, such that the poorest 20% actually pay nothing. How can a program like this create systemic change and improve the country's overall financial situation and set up for being able to have initiatives be able to come into a country, and it's a fertile ground for innovative health projects?
No, absolutely, and many people have thought that you wouldn't be able to have a health insurance scheme that would work in a very, very poor country. I think what Rwanda is showing that you actually can. As people pay into the system, they then begin to want to use the system because they've invested something in there. And that's part of the reason that drives them to use the healthcare is they've actually paid something. And even if the government is not recouping all that they have paid in, by them now coming in, they're able to need less care for advanced cases, and it's actually now preventative. Somebody has to pay for all of this, but the less that the system costs overall, the more care we can provide.
Great, excellent. Well, I've just handed this question. In taking a scaled-down, community-based approach to healthcare, do you see a greater number of women involved in looking after the health of their communities? It seems women often play a larger role in other community development projects.
Absolutely. I think women are essential. They're one of the reasons that the Bush Institute focuses our programs on women is because we really believe that a healthy, productive woman is a healthy, productive society. Most of these programs are run by and for women for good reason, because women are able to, they put often family and children first. They're able to save money and to do things that are good for their families, which is actually good for society. Most of the programs that we are looking into, most of these programs that are actually focusing on sort of these innovative programs around healthcare are almost always run by women. Which then sort of says to us men, we got to get with the program.
Totally. It was interesting to hear through your journey that you started serving underserved communities internationally through initially working with underserved communities in LA. And in your book, you had a table detailing key components of reverse innovation, going the other direction. And in it, you specifically called out a Partners in Health program that improved health outcomes in Haiti and Rwanda using paid community health workers, pointing out that it's now used in the U.S. with similar improvements. Can you tell me more about reverse innovation and how it sometimes takes demonstrated successes in resource-poor settings to unlock successful collaborations between policymakers and innovators here?
Absolutely, and in some ways, I think we may even want to get away from the idea of reverse innovation, because I think it's all just innovation. Something works one place, and we can use it another place. I think one of the exciting things about the innovation that's now occurring in many developing countries is that it's designed for resource limited settings, and those things can be extremely helpful here as we then as we are grappling with how do we pay for our own system. And I think the program that you're talking about, the Partners in Health program, they're now using that in Boston with great outcomes, and other communities are using it as well.
Great. Excellent. I've gotten a number of questions asking about the Pink Ribbon, Red Ribbon initiative, and specifically about combating cervical and breast cancer, and questions specifically asking about the current status of cervical cancer vaccines in Africa and Latin America.
No, those are all great questions. I think one of the things that's been extremely exciting recently is negotiations with Merck and GSK and with countries around reducing pricing for their cervical cancer vaccines so that countries can now buy them. And it was an announcement recently by Gavi to decrease the cost of those vaccines to about $4.50. And countries can now purchase these vaccines as long as they can show that they actually have the ability to have demonstrated the ability to do it themselves. And there's a number of countries that are beginning right now, and those will also be scaled up.
Great. I know that there's some questions about just the percentage of penetration of those vaccinations. I know in Rwanda, I think it's over 93% of young women are getting the full series of the HPV, which I guess in comparison here, I think it's somewhere around 25%. But do you get a sense of this, the penetration of the percentages of full vaccination series in other African countries, other countries in Latin America?
Yeah, and in Africa, the one that has done it right now so far is Rwanda, and they have done extremely well. They, in terms of being able to find, it's a school-based program, and they find all the girls in the community and make sure that they vaccinate them, and they will go track them down to make sure that they've gotten all the girls. And that's actually part of the reason why they've been so successful. Another place that they've actually done this is Bhutan, has also been successful in vaccinating all their girls. Now other countries are now beginning to build upon their success and learn from them.
Excellent. I just received this question. Have you done health interventions that are integrated into already existing services that may not be health related? Sort of layering on a health intervention on something that has a system of delivery that exists.
Well, these are the types of things that I think will help create the kinds of care that we need, because we have it already. Certainly when I was younger, you went to a pharmacy for medications, and you went to a grocery store to buy groceries, and you went to a gas station to buy gas. You didn't go to a grocery store to buy pharmaceuticals, but we do it all the time. And you certainly didn't go to a gas station to buy groceries, but we do it all the time. And it's this type of layering, I think, is going to be the ways that we can begin getting healthcare out there. So, for example, in many countries, you have these drugstores or chemists that are providing medications, but often people go there for medical advice, for diagnoses. And they're also selling a bunch of other things other than just medications. These are the kinds of systems that can also be used. Schools are also a great vehicle that we can then begin using around health education and getting out basic treatments out there. Coca-Cola is now working with schools in a number of different countries around clean water. So one of the things that we know is that in many, many countries, they don't have access to clean water. And almost always, women and girls are the ones who have to go get the water. So girls can't go to school because they have to go get water. So what now Coca-Cola is doing is putting clean water in the schools. So now the parents want the girls to go to school, so they can at least get the clean water. And while they're there, they'll learn something too. Mm-hmm. These are the kinds of systems that I think, and ways that we can begin thinking innovatively about how to use systems in order to provide care as well.
Great, excellent. Increasingly, people are seeing the benefits of using disease-specific funding or vertical funding programs from the Global Fund and from PEPFAR to rebuild the country's health infrastructure and develop robust platforms for primary care. In the words of an article you referenced by Julio Frank, how the focus on specific diseases has exposed the fault line in delivering services in places where people suffer from multiple health issues. Why is comprehensive primary health care system strengthening so important?
I think for a couple of reasons. The primary healthcare system really is the safety net for a society. And if we don't have the system there in order to provide basic preventative care and basic treatment we're going to have a lot of people fall through the system. And in the book we talk about really having both. In specialized care, there's tremendous efficiencies you get because you can really focus. Your clinicians get really, really good. The system can work better because you're just doing a couple of different things. However, in a more general system, you're able to see a lot more disorders, but it may not be as efficient because you're seeing so much. And what we really need are sort of both systems, a more generalized system as well as specialty systems, in order to take advantage of efficiencies in both.
I'd love to go deeper into this because one of the issues I see is that often parallel health structures can get set up that can often end up undermining a country's Ministry of Health. That often actually are the only ones that have a mandate to provide health for the most vulnerable populations. I just returned from a couple weeks ago from Haiti, where Partners in Health launched an ambitious teaching training hospital in Mirabelais. And the Abundance Foundation has also supported that, as well as the HRH program to train nurses and doctors in Rwanda. So how can we sort of do what you're describing of using efficiency to address health needs, but avoid setting up parallel structures, which seems to be a tendency in global health to set something up that can end up really long-term undermining the Ministry of Health itself.
Yeah, and one of the things I think has driven some of these parallel systems is donors. Donors who will want to sort of be able to tell their taxpayers or whomever, or their boards, that they've been able to have an impact. And the more focused you are, the easier it is to show an impact. As they now begin to work in partnership with others, and countries are beginning to direct them, that's also beginning to change as well.
So it sounds like it's partly donor education about a longer-term vision, that you may not be able to claim ownership just on your own, because partnerships, long-term partnerships, are kind of essential to actually making an impact on these intractable problems?
Absolutely. Okay. Absolutely. The other thing that's also beginning to push this now are businesses, because even though our economy is not the strongest, some of these economies are growing by leaps and bounds. If you look at the top 10 countries in terms of economic growth, they're all developing countries. In the past decade, 6 of the top 10 were all in Africa. And so businesses are now going there, and they want a healthy healthcare system. And so that's actually beginning to also drive the country's ability to create the kinds of systems it needs. On top of that, as these economies begin to grow, you have a growing middle class, or less very, very poor people who are now beginning to demand greater health care. And that's actually how some of these entrepreneurial programs are able to thrive, is that they're actually now going after that.
Great. I have a question that gets at this creating demand. Could you describe creating more demand for care and medicine? Is there a role for mass texting, radio, et cetera? How does new medical and health information reach everyone?
So yes. We need all of that because what's going to work one place won't work another place. Certainly, and what's going to work with one group of people is not going to work with another group of people. I am now 52, soon to be 53. I didn't learn how to text. The way I learned how to text is I had a 17-year-old who wouldn't answer my emails, wouldn't answer my phone calls, wouldn't answer me yelling from the downstairs to upstairs, "Brian, come eat." But he would answer a text. So I had to learn how to text. And so, if you were to try to use a text-based system with a person or a group like me, it wouldn't be particularly effective. However, it would be with younger people. It might be in some countries, but not others. And it really depends upon whatever group you're working with and what works with them. Create demand however you can create demand. A smart business doesn't create demand and say, now demand it. Who do they go to? They go to the community. They understand. They do focus groups. They test these things to figure out if it's going to work before they launch it. That's why these types of business skills and business models applied to public health will also work because they're already working. I mean, for many of you, and I talked about Coca-Cola, many of us remember, if you've traveled, Coca-Cola, even though they have the same name every place, tastes a little bit differently. Why? Because the local people want a slightly different, that's too sweet, it's too sour, it's too whatever. So they changed it a little bit in order to create demand. The same thing is true with these things.
How will Pink Ribbon, Red Ribbon partner with local caregivers and local NGOs to deliver effective prevention and care, do training and quality assessment?
The Pink Ribbon, Red Ribbon, like any good initiative, is going to use very many of the things that I've just sort of talked about, is that in each country it's actually going to be a little bit differently. But we recognize that in order for us to get this out and scale this up, it's going to require local communities embracing the issue and providing the services. And so each country, it'll look a little bit differently, and they will work with, these are all country-run programs. So Zambia runs its own program, and the Bush Institute and other partners support the government. And because we're guests of the government, and the government and the local businesses will run these things. And so that's actually very much the way we will work in Pink Ribbon, Red Ribbon, is that it will be locally controlled and locally owned with local outcomes. But that's one of the ways that we actually also do it, is that we monitor these outcomes to make sure that we're also, that the investment that's being made has the kinds of outcomes that are needed.
I have a question, actually. I'd love to hear more about this, sort of working closely with the government, supporting the existing infrastructure. This sort of gets at a different way. Donors often prefer giving money to organizations like Partners in Health because they know how the funds will be used. In many countries, governments delivered services are seen as corrupt. Any comments?
So one of the key areas that we sort of talk about in the model is accountability, is making sure that you have clear targets and indicators, and that they are actually met. And I think that's actually one of the reasons why some donors have begun working with many NGOs, because they're able to have that kind of accountability. I think that things have really changed in the ways that countries are working, and countries are working with donors, so that it's much more transparent, and that you have more clear systems of accountability.
I know that one thing that made Rwanda different was that a lot of they were able to harness a lot of different donor funds to align with their priorities and be able to sort of set the agenda and have sort of a unified direction. Is that lack of a single agenda often a challenge in a lot of the countries that you've been working in?
So yes and no. So the countries that we often go into, and I'm really speaking about the Bush Institute, and even countries that I worked in beforehand, is that we would only go in if we were invited by the government, if they were also going to be investing, if they were going to be committed to it. And so because these challenges are all over the place, one can decide where you want to go based upon the outcomes that you're going to be able to achieve. And so while the country is saying, yes, we own this too, the donor's also saying, okay, we're co-owners because we can decide where we're going to invest.
Excellent. Do you run into issues with where cultural values or traditions compete with the healthcare practices you're working to implement? How have you addressed this sort of issue or changed your approach to meet the local ideals or practices?
One of the things that I think is absolutely critical is that sort of my belief, that you really can achieve anything as long as you are using the cultural beliefs and systems to the advantage of the patient, and to begin to be really creative about that. People, when it became clear that circumcised males had about a 60% less chance of acquiring HIV, there was a question of whether we would be able to get men to be circumcised. And basically everybody said no. Adult men would not be circumcised. But in many countries, there actually is a rush to get circumcised because they really began to sort of think about, okay, how do we do this? How do we use this? And they thought about the message that they gave men. In some countries, they went to the military first. And because the military were valued and the military were revered, and they worked with the military to say, these actually wasn't that bad. I feel like more of a man. I feel more virile. And they began to sort of get this thing out there, and people began to sort of say, okay, I can do that. Or they had women talk about that they preferred to be with a man who was circumcised. And then men begin to sort of think a little bit differently. Oh, maybe it's not so bad. But you sort of deal with whatever you're dealing with in order to do whatever you need to do.
Excellent. I heard the story where a person who built a hospital in South Sudan and has always been honest with his 6-year-old daughter, showing her photos of the community it served and explaining the challenges faced by the people there, and why he frequently travels to South Sudan to ensure they have medical care. And one evening, his daughter said, brought her piggy bank and said, "Here, take it all. I want to help the people in South Sudan." And on returning from a subsequent trip, and showing pictures of the new visit, she became angry and said, "I don't understand. I gave you all my money. Why aren't things better there?" How do you see your role in helping people move beyond a short-sighted sort of quest for a quick fix? I saw questions also just sort of expressing a frustration, but how do you see, with your students, in Master of Education students, undergraduates, and with all the people you're working with, how do we have a longer-term horizon for making an impact on these really challenging issues?
I think it's an excellent question, and I think it's one that we all face. We are impatient people, and we want to see fixes right now. We're really impatient when we see our money going toward it. And so I think that we need to be clear and realistic about sort of what impact we can achieve. And sometimes, the thing that we measure can't always be number of lives saved. It may have to be number of providers trained, number of communities served, in order for us to be able to sort of see that we're having an impact. For people who've actually ever tried to lose weight, I would certainly, I have. And I know that if I exercise more and I eat less, I will eventually lose weight. But it does mean being realistic about what we can do. Even in losing weight, it's going to be, okay, how many calories did you intake today? How much exercise did you do? Because that's going to then predict the amount of weight that you've lost. And the same thing is true with some of our health programs. Lives saved is going to be a impact that's going to be many, many years out. Other things are going to be much closer that we can actually begin to measure.
On the flip side, I probably some of the frustration that people feel is because there isn't the same feedback loop that exists in business. Failed strategies often end up getting perpetuated within development that don't have, here in the Bay Area, it's sort of fail big, fail quickly, and move on, learn what's not working, and move on. That those forces aren't often at play in development and in global health work. What's a way that we could more quickly learn how sometimes we're perpetuating structural violence or systems that perpetuate the need for the victim in order to get the next donation?
No, absolutely. And so one of the things that we talk about in Pharmacy on a Bicycle is using this feedback loop, using this system in order to get an understanding of, are you going in the right direction or are you not? And if you're not, to change. That's what businesses do.
Excellent. And we have time for just one more question. This one, graduating medical students frequently have huge debts. I suggest that they be required to commit to pro bono work in countries where medical care is lacking, or even in the U.S. Where medical care is lacking. The payoff would be for doctors, and their debt would be reduced depending on their commitment. What is your opinion? And I know that Vanessa Carey has done an interesting loan forgiveness program and for people going into global health. But how do you feel about ways that we could use the large debt to have people address the needs of underserved communities?
I think one of the I don't know. I mean, I wish I could say that that there's a way that we actually could do this. I think part of it is a sort of understanding sort of where what sort of motivates people to do the work that they do. I actually work with a number of healthcare providers in Africa about purpose and about mission. And for many of them, the impact that they choose to have is not about making lots of money and doing really, really what they might think is well, but in saving lots and lots of people, in having this world be a different place because you exist. Those are the kinds of trade-offs that I think many young professionals are now making. Is my goal to be really, really wealthy, or is my wealth measured by something else than my bank account? And as we begin to change that dialogue, that there are intrinsic values in the work that we do, that we can have an impact on many, many people just by saying, yes, I will help here. Yes, I will do it. And what do you give me in return? Thank you. Or whatever it is, because that's all I need.
Excellent. Well, that concludes our program for this evening. On behalf of the World Affairs Council, I ask you to join me in thanking Dr. Bing for his excellent talk and discussion.